Good afternoon, everyone. I'd like to invite you to join us in the webinar for this afternoon, which is on COVID-19. And actually what we've been learning about COVID-19 and the impact on those who have rehabilitation needs as a result of any issues impacting on their voice, on the communication, and also on their swallowing. So we're very lucky to have a lineup which is fantastic, I think, and I'm just going to introduce myself first. So my name is Kamini Gadhok and I'm Chief Executive here at the Royal College of Speech and Language Therapists. In terms of who's going to be on the panel today, we're delighted to have Anushua Gupta, who is a GP, and she is also a service user. We've also got Dr. Camilla Dawson, who's clinical lead speech therapist at University Hospitals in Birmingham NHS Foundation Trust. Sarah Wallace, OB, consultant speech language therapist, Wythenshawe Hospital at Manchester University NHS Foundation Trust. Gemma Clunie, who's our clinical specialist SLT, leads in Airways ENT at Imperial College Healthcare. And Dr. Hannah Crawford, who's the professional head of speech language therapy at Tees, Eskin, Valley's NHS Foundation Trust. Wow, that's quite a mouthful. So just to say, in terms of how we're going to manage the event, we have asked our speech therapists to pre-record their presentations, and we're really grateful to them for doing so. And this was really in case urgent clinical work comes up and prevents them from joining the whole webinar today. However, they should all be available to answer the questions during the Q&A session towards the end of the webinar. I'm very aware that there may be questions that we cannot answer, but we will get back to you if we can't answer those today and make them available on our website as soon as possible. We're absolutely delighted that Anushua is here presenting live, so I shall be introducing her to you in a minute. In terms of the timing of the webinar is going to be held for approximately 1 hour altogether. So we've got about 50 minutes of presentations, followed by about 10 minutes for a Q&A session at the end. So before we get started, just a few housekeeping notes. As you know, staff at RCSLT will be on hand to help with any technical queries. And it's really important that you use the chat button for any technical questions or queries, so that we can look at queries or questions that come in for the Q&A for the speakers separately. So if you use the chat button for any technical queries and use the Q&A button for any questions, that will really help us to manage your queries in the right way. I'm very aware that not everybody's going to be able to listen in, as you're probably very busy seeing your patients. So we are recording this event and we're going to make it available on the RCSLT website alongside the presentation slides. However, for those of you who are listening in, we'd be really grateful if you could fill out the evaluation form that will pop up in the new window once the webinar window closes. Okay, and finally, if you do want to tweet about this, do join the conversation using hashtag RCSLT Webinar. So turning to the aims and objectives, the aim of the webinar today is to hear about the experiences from a patient of her journey, and particularly the road to recovery that she's been through so far. Also, we did have a webinar last year, soon after the pandemic first started, to really share what our members were learning as a profession. And it's really important now that we take stock to identify what we've learnt as a profession since the first wave of the pandemic. So you'll have an opportunity to get an appraisal of COVID-19 literature and what we know now, to hear about how others have implemented some of the most recent evidence. You'll have an opportunity to find out more about the tools that are available and the work that we have done to support the development of these tools. Also hear about key priorities for assessment and rehabilitation, and gain some understanding of how COVID-19 has impacted on people with learning disabilities and mental health. We're also going to be sharing some other tools with you that we have on our website. So let's turn to our first speaker. I'd like now to introduce Anushua Gupta, who is a general practitioner. She's married and she's a mother of a 2-year-old girl. Anushua contracted COVID-19 in March 2020, and I'm just going to pass over to her now so that she can share her personal experiences about her admission and post-hospital rehabilitation. Over to you, Anushua.
Thank you, Kamini, and thank you for having me on here. It's a great honor to come here and speak about my journey. So as you said, I'm a GP, and I contracted COVID sort of back end of March 2020. And as healthcare professionals, we kind of just get on with things, even if we are unwell. And at the time when this happened, I remember, I mean, I'm an asthmatic. So at the time I was just very breathless, quite tight in my chest. And I thought, this is probably just my asthma playing up. Until, as you know, a few days later, things just started getting much worse. At which point, you know, my husband and I thought, no, I need to get this looked at. I need to go into hospital. So, you know, I obviously went in thinking it's just an exacerbation of my asthma. I didn't get to say my goodbyes to my little girl properly because I thought, right, I'm going to be back in a day or two, you know, after treatment. But sadly, that wasn't the case. So I was admitted initially on the 30th of March and got much worse. And then the early hours of 4th of April, I was ventilated. And I remember that night very clearly, actually. I was very, very breathless that night, really struggling to a point. I remember I spoke to my husband. I called him and I said, you know, I just want this to end. I don't want to live. I'm just so breathless. And a few hours later, the ICU consultant came and told me the news, which any patient would dread, that I would have to go on the ventilator. And at that point, I just thought, because of how breathless and how unwell I was feeling, that that was going to be the end of it all. I called my husband and I didn't tell him those words because I needed him to be brave for himself, for my little one. So I told him the news that this is what's happening, and to show me Ariana, my little girl, you know, to show me on the video WhatsApp call. And sort of deep inside, I was almost saying my goodbyes, and that was really hard. And obviously after that, the rest was sort of history, you know. The next thing I knew was when I woke up in CTCCU. But obviously, after I woke up, you know, you start to piece things together slowly over time. And so I knew that 10 days after being ventilated, so on the 14th, because I had deteriorated, I had to go on ECMO. So luckily for me, it was Dr. Julian Barker, who's the ECMO director at Wythenshawe Hospital, who had actually cannulated me on the night of the 14th of April. And, you know, for a long time, things didn't change. Things were not getting better. On the 13th of May, my husband was brought in by the consultants to actually have the end of life chat because they thought that I wasn't going to make it. And that, I can't imagine how incredibly difficult that was for my husband. And obviously, you know, I'd gone through various trials or various treatments. Nothing was working. I wasn't picking up. And for a long time, you know, people thought that I wasn't going to make it. Things were not improving. But miraculously, after the 13th of May, things started to take a turn for the better. And I eventually came off ECMO on the 16th of May. So 34 days on ECMO. And then on the 25th of May, I had a tracheostomy. And then slowly they started to reduce the sedation. And that was a very odd experience, you know, slowly coming out of sedation, because I was quite confused. You know, there would be periods where I'd be with it and then periods where I'd be asleep. And then obviously that was the time when I started to realize that I didn't have a voice because I couldn't hear myself talking. And then trying to get my needs across to the nurses was very frustrating because, you know, naturally not everyone can lip read. Some of the nurses could lip read, which was helpful. But, you almost feel locked in, not being able to get your needs across or your thoughts across. And I remember cleverly, once when I was lying there in CTCCU, I realized I've got a SATS probe on my finger. So one way of maybe getting someone's attention was to bang my finger on the bed rail, to get somebody to come over to me, because obviously I couldn't shout over to anybody to come over to me. So that was one thing, having no voice. The other big thing was not being able to drink. So we're talking sort of June almost, so it's very warm, and not being able to have a drink, it was really, really difficult. I remember, I can't, whether it was Sarah or not, I can't remember exactly, the first scope that I had. I was told that obviously there was a lot of laryngeal edema and it wasn't safe for me to drink at that point. And I'd have to wait another 2 weeks to be rescoped and then decide whether, I'd be able to have any oral intake. And that at the time felt like a lifetime. To wait 2 weeks, not having even a drop of water, that was really, really difficult. And I think when I was rescoped, I still wasn't ready to have any oral intake. So that was when my heart sank, really. So that was one thing, not being able to drink, the fatigue, being tired and fatigued. And then I remember I was having periods of where my cough would be up and then down. So when my cough would be down, it felt so good. I felt like I had a small voice at the time, barely a whisper. And then also I felt like I could breathe properly, because as soon as the cough went up, I felt like I was being strangulated. So that was frustrating, because obviously I had to be weaned on that, periods of cough being up and down. And then I was transferred off to ICU from CTCCU on the 18th of June. I saw my husband for the first time on the 19th of June, the day after, and that was amazing for us both, obviously. The other big step was coming off the ventilator. So, this contraption that was keeping me alive. So I have a lot of respect for it, but I hated being on it. It was awful. The secretions, the coughing, the gagging. So, coming off the ventilator was a very daunting process for me. I remember saying to the nurses, just don't tell me when you're dropping the pressures. And I think that really worked for me. But obviously when there were periods of time where, there were long periods of time when the pressures were low, I could feel it. But, I came off the ventilator. It was done slowly under Professor Bentley's, care. And, the staff at ICU were absolutely amazing. They really, really looked after me. The other issue that I had whilst I was in ICU was the profound muscle weakness because of being in ICU and, sedated for so long. So I had a lot of physio, which was also very daunting. I remember my stomach would turn every time the physios would walk through the door, but it had to be done, And then with regards to starting to eat, that was something that I was very petrified about. The first thing that I actually ate, that I actually had, was sips of cold milk, and that was a godsend. I remember, I think it was Sarah, and that was amazing when I could actually drink a little bit of milk. And then I think I had a little bit of yogurt, which was great. And slowly, Sarah directed how I would eat. Although I was still petrified about that, it started off obviously with, a soft diet, pureed diet. But I think the moment there was any bits in the food, that really made me very nervous. There was a time when I had Heinz chicken soup, with the bits of chicken, and I would feel that would be stuck in my throat, and that caused a lot of anxiety for me, because I thought I was choking. But that remained for quite some time, this hypersensitivity. So anything that was not pureed, anything with any texture, it would feel like there were bits stuck in my throat. And that almost lasted up until a few weeks after I'd come home. So that was quite frustrating. So I think I was transferred from ICU to the rehab ward on the 16th of July. And I remember even at that point, I had no smell, no taste. I had almost zero appetite. I didn't want to eat anything, but obviously had to force feed myself almost. And to contend with that hypersensitivity and the anxiety of that feeling of things being stuck in my throat. And then eventually, you know, as I was getting stronger with the help of physio, which was one of the main things of being in the rehab ward, I went home after 150 days of being in hospital on the 1st of September. And as I mentioned, you know, I was 3 to 4 weeks of being at home, still having issues with not being able to taste, zero appetite, and that hypersensitivity, which sort of almost suddenly just left me. You know, I can't even say that it was gradual. It was just one day I woke up and that hypersensitivity wasn't there anymore. And I was able to enjoy my food again. It was like it suddenly, you know, my senses had just come back and I started enjoying food. And then the other thing, I started, one of the main things for me, as you know, I'm a GP, main thing for me was my voice, you know, because I speak so much in my job, and I was so worried because when I came home, my voice was still not of great quality. People couldn't hear me if I needed them. So my husband ended up getting me a pendant buzzer, which made me feel quite, you know, I felt like I was an old lady, you know, in a nursing home, but it was needed at the time. Gradually, obviously, my voice has slowly gotten stronger. I'm not able to sing rhymes with my little one, which frustrates me because she wants me to sing with her. But I can't do that just yet. I can't quite get the pitch right. But the voice is stronger because I started doing telehealth work on the 14th of November. And at the time, I could only manage about 1 or 2 hours of speaking. And I would feel so tired at the end of it. And my throat would actually hurt quite a bit at the end of it, at the end of the day, on those days that I did do work. Slowly, I have built that up. I'm still doing only a few hours, maybe just a handful of times in the week. But I am finding that is still a problem. You know, having a slight sore throat at the end of the day, and waking up with a thick mucus plug. I just can't understand that one. That's quite frustrating. And sometimes that can feel like I'm being suffocated. And until and unless I actually get that mucus plug off my throat, it just feels very irritable. So that's an ongoing problem. So I'm going to be at the voice clinic on the 15th of February, where I will be rescoped for Molly, who's my voice therapist. She'll be having a look to see what's going on. And we're doing a lot of exercises, voice exercises to help, you know, build up my voice quality. And that is really helping. I certainly feel that my voice quality has improved a lot since I've come home. So that's really been my journey. Yeah. And I just want to take this opportunity to say a huge thank you to Sarah and her team and everyone in ICU and CTCCU. They're the reason I'm here. And I can only be thankful for that. So thank you so much.
Well, thank you so much for sharing that experience. It sounds really harrowing, and also, I guess, you know, the positive future that you have to look forward to is really good for everybody to hear from where you were last year and those dark moments, you know, to where you are now. So that's great. And I'm sure that the journey of rehabilitation will just continue in the way that we would hope. So, and obviously nobody's seen this virus before and what it can do, and the impact it can have. And I think, thank you so much for sharing all that, because I think that real life experience that you've had, and, you know, nobody would understand how that must feel unless they've been through it. So I think we're really grateful to you for showing that, Anusha. Do stay on the call and
Yes, I
listening,
will
because
do.
obviously we'll have the Q&A at the end. So thank you so much. So I
No
want
problem.
to now pass to Camilla. Now, Camilla actually recorded this earlier for us in case she had to disappear and not be able to do the whole presentation. So Camilla is going to introduce her presentation herself, which is looking at the literature, the evidence and the practical application of that.
Hello, I'm Camilla. I'm the clinical lead for speech and language therapy at the Queen Elizabeth Hospital in Birmingham. I'm an honorary research associate at the University of British Columbia and an advisor to RCSLT in critical care. So we are going to explore the literature that's available about COVID-19 and dysphagia. We're going to talk about how we navigate this evidence and synthesize it. We'll talk about practical applications, how to create efficient and effective services, and how we look after each other in these challenging times. As a disclaimer, this is not a systematic review. It is an overview of the evidence for clinicians working in the field. So the primary research which is emerging is really helpful because we didn't have this in the first surge. Some of this evidence is telling us that patients who have been intubated and ventilated as a result of COVID-19 may recover their swallows quicker than those who traditionally we would see with post-extubation dysphagia. Video fluoroscopy studies are telling us that patients have silent aspiration as a result of sensory motor compromise following COVID-19. That actually there are laryngeal complications which involve vocal cord palsy through to laryngeal edema and other sequelae associated with not only intubation, but potentially the impact of the virus itself on the upper airway mucosa. There's some exciting work which will be coming out of Sarah Wallace's group later on in the year. We also know that for patients who are admitted to hospital, big proportions of those who are admitted for over 3 days required speech and language therapy assessment for their dysphagia in our hands in Birmingham. And that was important as 30% of patients who required our interventions were presenting with significant dysphagia whilst they were in hospital as a result of COVID-19. We also know that following discharge from hospital, voice, swallow and airway outcomes need to be assessed, and we're noting things like subglottic stenosis and pervasive laryngeal compromise, which I'm sure Gemma will speak about as she presents. The literature reviews, which were published around the same time as some of this emerging evidence, if not before, are reassuringly similar to the evidence which is now being published, which has patients involved. So the literature reviews told us that we should expect to see breathe-swallow compromise, that there would be neurological compromise to swallow, and that actually as speech and language therapists, we needed to be mindful of the limitations that may be involved without using instrumentation in the first surge as a result of the aerosol generating procedure that was. These also told us that actually we needed to be innovative as speech and language therapy teams and ready to use things like telemedicine to challenge the way and change the ways that we had historically provided care outside of the acute sector. Consensus statements also emerged. These were really helpful, especially when defining the role of speech and language therapy. These statements told us about how we might optimally manage patients who are in the ICU. At this stage, they were also telling us things that we should be avoiding, such as cuff deflation and changing tracheostomy tubes. And obviously, some of that information has now changed as we've experienced these patients firsthand. Other pertinent literature, which I think is important to note, DONT paper, that explores the pathophysiology of happy hypoxemia. So this is about patients who present with hypoxemia as a result of COVID-19, who seemingly have quite limited symptoms and aren't compromised in the way you would expect them to be. This paper really gives such a wonderful overview of what that pathophysiology is, and it's really useful for speech therapists. The recovery trial is a really important trial in the UK, which is looking at therapeutic interventions which are likely to improve outcomes for people with COVID-19. So from drug interventions through to high flow, through to CPAP trials. It's a really important trial. The COVID Track Collaborative is an important paper as it starts to tell us that tracheostomy is safe for patients with COVID-19 who have been ventilated and intubated. And moreover, our paper, which then went on to define what the trajectory of recovery might look like for those patients with the first 100 patients we saw with tracheostomies, tells us that we were able to decannulate patients usually within 14 days, that 49% of those patients were decannulated directly from their first tracheostomy, but 18% of those patients needed downsizing and fenestration, which is absolutely in line with the information we see about laryngeal compromise, edema, vocal cord palsies, and upper airway compromise. We're seeing that same pattern now in our institution. So I would alert people to this and to be mindful that downsizing and fenestration was a useful therapeutic intervention for us. This slide is totally biased. It is papers that I refer back to when I'm finding myself with clinical conundrums. Of course, Bonnie Martin Harris, Madison Macht, Susan Langmore, and Stacey Scoretz are on there, who I think just provide us with cornerstones of understanding of breathe-swallow interactions through to post-extubation dysphagia. It's really important to note people like Martin Brodsky, who have provided so much to us in this first and second surge with regards to post-extubation dysphagia. And there are, of course, huge numbers of other people from Anna Miles, Liz Ward, all of these people that provide us with such great overviews of what dysphagia is and how we should be optimally managing it. And I would urge people to refer back to some of those cornerstones of how we manage dysphagia and the evidence that's available to us when you're feeling overwhelmed by clinical circumstances that are challenging. Navigating this evidence, I would suggest you're specific. So as I've said, use the appropriate literature to answer your clinical questions. At the beginning, I said that there was a disclaimer that this wasn't a systematic review. It is not. And if it was, I would be recognising all of the limitations to the empirical evidence that is emerging, that methods have been compromised within our own paper as well as a result of not using instrumentation. Be very careful about the ways in which you implement some of this literature, recognise its limitations, but also celebrate what it brings to us and how grateful we are to everyone that's publishing at the moment to provide us with some information on this challenging clinical presentation. I would suggest you create a hypothesis and triangulate your clinical picture with the evidence we have previously and the emerging evidence, so you can start to create a working picture as to how you may provide rehabilitation. Ask questions, and I would suggest avoiding binary diktats about what you can or can't do. Really, I would be suggesting you're generating hypothesis about the ways in which you might expedite rehabilitation. For us, dysphagia was prevalent in people that were admitted hospital. I would also say now we're in the third surge in the UK. We are finding it to be absolutely as prevalent, if not more so, than it was in the first surge. We will obviously be publishing on that in the future. We found that people had delirium, which was hyper or hypoactive, laryngeal compromise, which is reassuring because that's emerging from the literature now, respiratory swallow coordination challenge, burden of secretions, and significant fatigue as a result of that. The way we managed it, we provided exercise, practiced swallows. We did augment texture and complexity of diet and fluid as required. I would really urge people never to over thicken drinks because, as so many people have published, that's not good for anyone. However, for certain groups where they had significant anterior loss in early phases and had issues with mastication, small amounts of thickener were useful. Avoiding distractions and recognising upper limb weakness was useful for those patients that have been prone, for example. Really important to recognise the majority regained nearly normal swallow function prior to discharge, regardless of the length of intubation or tracheostomy status. However, these patients are likely to need follow-up in the future in the community, which I know Gemma is going to speak to in her presentation. So the practical application of this literature is about staff repurposing, it's about decompressing ITU, it's about avoiding people having readmission to ITU because they require a tracheostomy again because they have pervasive dysphagia. It's about flow through acute services when beds are at a premium. It's about strategic decisions that move beyond just those for a speech and language therapist, but for speech and language therapy within a therapy and a medical team, and avoiding secondary infections. When patients have COVID pneumonitis, they don't need aspiration pneumonia as well. We would suggest creating core aims and objectives which are manageable, bringing your team along with you so that you're defining all of the same things together and wanting to create the same outcomes together. Utility theory is useful. Think about your trade-offs and being deliberate. Jonathan Barron is a great read at any of those times where you're stuck between what you can and what you should be doing, and keeping governance core to what you do and when you do it, when we're thinking about safety of patients who have dysphagia. Looking after each other is fundamental. So our own emotional responsibility, but our responsibility to others amongst us. Supervision and debriefing is really important. Ensure you have adequate sleep, rest and recovery, and create routine rather than relying on adrenaline to keep you going. We suggest you give space for the unexpected when you just walk onto a ward or into a circumstance that can take your breath, that just makes you feel overwhelmed. Give space to kind of decompress and talk about that together, and explore what your triggers, responses, and the implications of these might be at work. We need to be there for each other to support one another. It's really important. So our lessons learned: dysphagia is prevalent in the cohort of patients with COVID-19. We need protected and adequately funded SLT services. Avoid paralysis by analysis. There are absolute tensions in managing guidelines, consensus statements, empirical evidence, and then the people that are in front of you. Know what you're looking for, why you need it, and how you're going to employ it. And provide adequate supervision and support, because we have to support one another absolutely at the moment and long term. Thanks very much.
Thank you so much, Camilla. I think everybody will agree that was a really interesting overview. I'm now going to pass over to Sarah Wallace, and Sarah's again pre-recorded her presentation and will be available to answer questions hopefully at the end of this presentation. So Sarah's going to talk a bit about the sort of tools and resources that you are also able to use. So over to you, Sarah.
Hi. I would like to start by just saying thank you for the opportunity to speak on the webinar. So I'm Sarah Wallace, and I'm a consultant speech and language therapist, and I specialise in dysphagia and critical care, and I work up at Wythenshawe Hospital in Manchester. So I'm going to talk to you about tools and resources that have become available since the last rehab webinar that we did. These are both for other professionals in terms of signposting to SLT, but also for us as SLTs to highlight to other people and also to use with our own patients. So the first resource that I'd like to draw your attention to is the NHS Your COVID Recovery website. This is a digital platform for patients, and it's actually the official website developed by NHS England. So this was a two-phase project, and it involved a very broad multidisciplinary project team with input from us, our RCSLT advisors. It was led by Camilla, and also Nicola Pargeter, Gemma Haynes and myself worked together on this project. And we basically helped to shape the website design, but also helped to write the content for the sections which are dedicated to swallowing, voice and communication. So phase one of this project was to develop the website for patients who are in community, self-managing their COVID-19 symptoms. It was launched back on the 31st of July and actually has had over 600,000 users to date and some really excellent feedback. So please take a look, tell your colleagues about it, and any potential users that you can think of, direct them to this website. So phase two of this project was actually to develop a digital rehabilitation package. This package can be individually tailored to your patient's needs. It requires referral and assessment by a healthcare professional before you can actually access the platform. it's particularly useful as an adjunct, I suppose, to rehab for anyone who may be able to benefit from self-management with virtual guidance and support from the professional, so from the SLT. It's also interactive, so there's interactive goal setting and monitoring progress, and the patient can actually ask questions or share concerns through the portal. So there are sections for SLT, physio, dietetics, psychology and OT. So why don't you think about registering your service if you wish to? That's the address there. And when you do so, you actually then receive training on how to use the platform. So other work that has been done has been targeting GPs and highlighting about COVID, but in particular about post-intensive care syndrome. So the Intensive Care Society ran a webinar for the Royal College of GPs, which I was asked to contribute to in order to raise awareness of PICS. And the ICS Rehabilitation Collaborative Group that we formed last year, early on in COVID, are also currently making a film for GPs on the same topic. So for the SLT part, I'm going to be covering voice, swallowing and communication, cognitive communication and airway issues in terms of what to look for, screening tools and referral signals to SLT. We have also produced what we call an infographic leaflet, which is also for GPs to again highlight some of the key concerns that patients may present with. I'd also like to highlight an update that we have made to the comprehensive SLT section of the rehabilitation framework that we devised with the Intensive Care Society. So this is fully endorsed by RCSLT. It's available on both the ICS website and the RCSLT website. And again, this is for any patients actually. This is not just for COVID patients. And it has suggested tools and questions that you or other professionals can use to indicate a problem and a need for referral to SLT. So hopefully this is a helpful resource for everybody. And just finally from me, an update on the Pickups tool. So this is the screening tool, which is part of the rehabilitation framework that I just mentioned. This tool, if you haven't used it and you're not familiar with it, should pick up the need for SLT intervention. It also assesses rehab needs at ICU step down and provides a rehab prescription if needed at the point of discharge from the ward to home or to rehab facilities. So the work that subsequently has been done is around piloting this quite extensively in 26 hospitals. We have pulled together all of that data and are about to publish 2 papers on the clinometrics, the validity, the reliability of the tool. And we've actually slightly updated the tool as well from that work. But also we've devised some bespoke software packages and user support for data collection, which is available for any site that registers to use this. And actually Intensive Care Society are encouraging all ICUs to take up this this tool and this piece of work. So that's an update from me. I'd like to thank you very much for listening, but also I'd like to thank very much Anushua for her very brave account earlier on, and I very much appreciate her giving her time to us. Now I'd like to hand over to Gemma.
Thanks so much, Sarah. That's wonderful. Thank you for that presentation. So as Sarah said, we now have Gemma's presentation, which she also did pre-record for us. So Gemma Clunie will again introduce her topic area and herself. Thank you. Over to you, Gemma.
Thank you, Sarah, and thank you to RCSLT for inviting me to give this presentation on COVID-19 and speech and language therapy, the clinical priorities. It's a real honour. My name is Gemma Clunie. I'm a clinical specialist speech and language therapist in Airways and ENT at Imperial College Healthcare Trust, and also an NIHR clinical doctoral research fellow. I just want to say some thank yous at the beginning of the presentation. I'm not a neurospecialist, so I reached out to some colleagues at the National Hospital for Neurology and Neurosurgery, Dr. Mike Zandy, a neurologist, Charlotte Massey, a physiotherapist, and Jodie Allen, a speech and language therapist, and also a couple of speech and language therapy colleagues as well, Freya Bell and Kate Harrell, just to clarify that some of the points that I was making were true in the context of working with neuro kind of COVID presentations. So thank you. So what are we seeing in terms of COVID-19 and the symptoms that are relevant to speech and language therapy? First and most obviously, the respiratory symptoms, so the breathlessness, the cough, the mucus, and this can be either in the acute phase or more chronically as patients are recovering, whether that be at home or in the hospital. Laryngeal symptoms, so dysphagia, dysphonia, globus, so that horrible sensation of something being stuck in your throat when you swallow. And obviously the more complex airway issues that I would see in the clinics that I work in, such as laryngotracheal stenosis or even vocal cord palsies. And these might be as a result of intubation damage, but particularly in the case of palsies, might just be as a result of COVID-19 viral infection without ever having been in hospital. Fatigue is a huge problem for patients following COVID-19 infection, as are mental health difficulties, and these things obviously come hand in hand. If you're too exhausted to be able to do things, this will have a huge impact on your mental health, and I know that Hannah's going to talk about that a little bit later. Cognitive and neurological symptoms, so this might be memory and concentration difficulties, it might be attentional deficits such as speed of processing or information encoding, and this could be as a result of the breathlessness and the fatigue that I've already mentioned, or it could be a kind of lingering inflammatory response, or it may be that the patient has actually had some kind of neuro event that shows up on the CT or an MRI, but clearly they're symptoms that are relevant to us. And finally, the gastro symptoms, things like reflux or a feeling of fullness that means that you're not very interested in eating and drinking. Some patients complaining of ongoing taste disturbances, and that can be quite reminiscent of, for example, the radiotherapy population in head and neck cancer who just don't want to eat and drink because things don't taste right. And this has quite a huge impact on nutrition, and that has an impact in itself on recovery. So it's something we really need to be mindful of. So just to talk a little bit about post-COVID-19 syndrome, long COVID, the NICE guidance describes it as the signs and symptoms that develop during or after an infection consistent with COVID-19 that continue for more than 12 weeks and are not explained by an alternative diagnosis. Now, the NICE guidance doesn't name speech and language therapy as a profession, unfortunately. I know that college really tried hard to make sure that we would be, but weren't successful. But that doesn't mean that we shouldn't be involved in these patients. It just might mean that in terms of funding streams, that it's more challenging for us. But we know that patients with long COVID have word finding difficulties, acquired disfluencies, they might be chronically coughing, and these are all issues that speech and language therapists can help with. Just looking on Twitter, you know, this might only be kind of patient, you know, individuals talking about their problems, but I think it's still quite disturbing when you realise that patients are having these kind of difficulties. So when I was preparing for this presentation, I came across a preprint, and I know that Camilla has talked about how important it is to be mindful of the evidence that you're using. But it hasn't been published yet, but it is a fascinating survey. It's an international cohort, as it says, 7 months of symptoms. They cover 202 symptoms, and they surveyed over 3,700 individuals who had what is called long COVID. In terms of the speech and language therapy symptoms that were drawn out, there was difficulty swallowing in about 30%. Changes to the voice, facial paralysis, and then perhaps a little bit more disturbingly, over 49% of the respondents described speech and language therapy issues or speech and language issues. And this is why we really do need to be trying to kind of pick up these patients where we can and where resources are available to us. I know it's incredibly challenging at the moment, but we don't want these patients to kind of fall off a cliff in terms of what they're being offered, or not even realise that there is therapy available to them. So what are our assessment priorities? It's really hard. It's a novel virus. We still are learning so much about it on a day-to-day basis, and the virus keeps mutating, which means that there could be things that are very different in 6 months' time as to now with our patients. But we do need to just be curious, ask the right questions. I always find that that is often where I learn the most with my patients, is when I'm kind of basically a bit nosy and kind of try and find out as much as I can about them. And be innovative. You know, there might not be a standardized assessment available to you, but I'm pretty sure you'll have something informal that you can adapt and use with the individual that you have in front of you. Instrumentation is key. Camilla's talked about that in relation to dysphagia, and it's true, for example, for voice difficulties as well, that if you can get an endoscopic view, you really should. But that might mean, you know, if you're in the community and you don't have easy access, that you just make sure that the referral has gone in and that you're still working with the patient, but being honest about the limitations kind of in the short term if you haven't actually seen kind of their larynx, for example. And similarly, if they have sort of neuro signs, but they've never been in hospital, making sure that they are being signposted for imaging studies or for neuro review if needed. Use outcome measures, they're key. They really help to guide our therapy, they help to collate data on this new virus, and they help patients to see whether they're improving or not, and then problem solve what they can do about that, or what you as a therapist can do about that. So they're really powerful. I've already mentioned mental health. I think a key point is that some patients are really experiencing high levels of shame and stigma because of COVID-19, and we really need to be kind of supporting them with that and signposting them to other services if needed, as Hannah's going to talk about in a moment. And this idea of readiness for therapy is really helpful when we have such huge caseloads and we're trying to kind of problem solve who we should be seeing. You can triage based on this idea of if a patient isn't really worried about a problem, even if you've picked up in your assessment, it's not going to be worth doing therapy on. And I've noticed that, for example, in the patients I see in my clinics, they might have a perceptual voice difficulty, but they might not be bothered about it. So I'm not going to work on their voice because that wouldn't really be very effective. And then, you know, you give them information, tell them to come back, but at least you're not kind of using up your time and theirs unnecessarily. The management priorities are really key to this notion that their recovery is, as a patient said, a roller coaster and not an incline. They don't necessarily get better in a kind of linear trajectory. For many patients, one symptom might be replaced by another, and they can vary day to day in a kind of relapsing remitting type pattern. So any therapeutic input needs to take account of that and be considerate of that for patients. Self-management is key. We know from other work with chronic illnesses that people who successfully self-manage their conditions have much better health outcomes. So this idea of kind of patient activation, using systems like the Your COVID Recovery Programme, or even just something simple like a symptom diary to kind of keep track of what triggers their laryngeal sensitivity or their fatigue, is really important and will help to empower your patients to have much better outcomes. Be individualised with your goal setting. So what are their priorities? And be realistic as well, though. If they're talking about being back to how they used to be, but they're still crippled by fatigue, then you might need to be kind of introducing a sort of what is going to be good enough concept for them. And that will help them to come to terms with what they are able to achieve in the short term. And, you know, think about the changing priorities. The person's trajectory in their kind of life and the demands that are placed on them will probably change with time. So, for example, those patients I talked about with dysphonia, they might go back to work and realise that their dysphonia is a problem and they do want to work on it. But they won't know that until they're back at work. And then finally, work with your team, work with your multidisciplinary colleagues. We can't do this on our own. We need to work together. They need to refer to us. We need to refer to them. We need to just be constantly making sure that we're kind of trying to support our patients and ourselves in the best ways possible. And acknowledge the limitations. This is a new virus. We're still learning. We don't know all the answers. And it's okay to tell your patients that as well, and to tell yourselves that and your teams that. What you have is good enough, but it might seem really, really hard right now. You're trying to work in PPE, which limits your communication and impacts on therapeutic relationships. Everybody's got issues with staff absence and the impact of COVID-19 personally, with family members being sick, for example. There's different organisational policies and programmes in terms of redeployment, or whether you can use telehealth or remote management, or whether outpatient appointments have been completely cancelled because of surge. We all have to recognise the limitations of our therapeutic input at this time in any setting and be kind to ourselves. And if you need to, ask for help. You're not alone. I'm going to hand over to Hannah in a moment, but I just wanted to say that I have a lot of resources from having developed this presentation. I'm very happy to send out to people. RCSLT have my email address, and I think we'll probably be sending them out hopefully as well. Thank you very much.
Thank you so much, Gemma. That was amazing. Thank you. And thanks for your the opportunity to share the information that you have through us too. That's fantastic. So we're now going to view a recording from Dr. Hannah Crawford. Again, she will introduce herself and her topic area. So over to you, Hannah.
Hello, my name's Hannah Crawford. I'm the Professional Head of Speech and Language Therapy at Tees, Esk and Wear Valleys NHS Foundation Trust. Within Tees, Esk and Wear Valleys, we offer services to people with mental health and learning disabilities. And I'm here to talk to you about the impact that the pandemic has had on these populations, but also the impact the pandemic is likely to have on people without pre-existing mental health conditions. So, in a report by Dimensions, in association with the Learning Disability England and Voluntary Organisations Disability Group in 2020, this group reported that people with learning disabilities feel more isolated from society due to the pandemic, and that includes people with a learning disability and/or autism. And anecdotally, we see, particularly at the beginning of the pandemic, that care providers were wanting to avoid community contact for the people that they care for. And also we have some groups within this population who fall into the extremely vulnerable category and will have spent a long time shielding. This group report that they feel like they don't matter compared to other people. 76% of respondents with a learning disability and/or autism have reported that feeling. 75% worry that after the pandemic, they won't get the same opportunities that they had before. 97% feel that government should do more to address their specific needs. And 97% say it's important that more people understand how coronavirus has affected people with learning disabilities and autism. In terms of the physical impact that coronavirus has had on people with a learning disability, in a summary report by Public Health England, based on the work done by the leader team at the University of Bristol, they report that the death rate for people with learning disabilities is 2.3 times that of the general population. If we take into account the phenomenon of underreporting, then the estimate is that 3.6 times the general population of people with learning disabilities have died as a result of COVID-19. In a large study done by UCL, the COVID-19 social study, where 90,000 participants took part, then there is reports of impact of COVID on mental health of those without pre-existing mental ill health. So 69% of people report that they're somewhat or very worried about the effect that COVID-19 is having on their lives. 63% worry about the future, 56% feel stressed or anxious, and 49% of people report feeling bored. There are harder hit groups in terms of the impact of coronavirus on individuals' mental health, and they include young adults, women, those on a lower income, and those with pre-existing mental ill health. And it is important to bear in mind that those with pre-existing mental ill health, both working age adults and older adults, are also more vulnerable to physical health conditions and will be more likely to see impact of COVID-19 on their physical health as well as their mental health. In terms of the key drivers for the impact of coronavirus on mental health, these include social isolation, job and financial losses, housing insecurity and quality, working in a frontline setting, a loss of coping mechanisms, and a reduced access to mental health services. If we move to the impact of coronavirus on children, there is a risk of increased stress and reduction of supportive resources and a risk of related post-traumatic distress. We see an increase on poverty impacting on housing, nutrition and well-being for children. And in a report by UNICEF in October 2020 and a report by the Mental Health Foundation at the end of last year, we see an impact for children more broadly on antenatal care, but also on their education. And for children living in violent households or suffering exploitation or abuse, the impact of the virus is more significant. And we are seeing an impact of the virus on the mental health of children as a result of these factors. At the end of December last year, the Royal College of Paediatrics and Child Health reported a 4-fold increase in eating disorders. The evidence around the impact of coronavirus on people with mental ill health, on people with a learning disability, and on the mental health of those who previously did not have pre-existing conditions is developing. But this is a summary of the evidence that exists so far. There are a multitude of sources of support for people, and the national charitable organisations, many offer support online, and there is a nice collection of links on NHS England's website, and the link is included here. Many mental health trusts have developed their own web-based resources, and we are urging individuals to contact their mental health trusts and their GPs to seek support as required. And we are seeing the developments of resilience hubs across the UK who will be able to help support. Thank you for listening.
Thank you very much indeed, Hannah. And finally, I just want to outline some of the guidance and resources that are available on the RCSLT website. And there's a link here to the website page where you can find some of these really useful things. So it does include the recordings of the past COVID webinars, which I think would be interesting actually to see how we've learned more about the impact of the virus since last year. We've also very importantly got information around health and well-being and resources for all of you. We're very aware of the impact at the moment around all our members and the teams that you work with. We think and we do know that there are lots of potential options for taking these up locally, but if you do need any other help, then please do have a look on the web pages and join the discussion forum for any peer-to-peer support. In the next slide, it just highlights really the work that's been done on developing guidance in relation to COVID-19, obviously with and through our members. So here's a list of things that is available, and we hope that, again, you'll be able to have a look on the website and see, how you can use some of these for yourselves. So I'm just aware that we're beginning to run out of time, but I do want to take some of the questions. So we had a number of questions that came through the Q&A function. I've been keeping a quick eye on them. So one is from Gary, who's asked about what high quality headsets are recommended to be able to assess voice virtually. I'm not sure if anybody's able to answer that one. That's a new one, but I don't know if anybody's come across that's on the panel.
I'm not sure, but I know my voice experts in my team can potentially answer that. If I have an email address, I can put them in touch with people, unless Gemma knows.
Hi, I am here. Can you hear me?
Yep, we can.
Okay. I mean, we're using Microsoft. I've actually got them here, but I don't know if my camera's come on. It should have done, but it doesn't seem to want to work. But again, yeah, I can email with what we're using if that's helpful, if the member wants to send their
Okay, I think Gemma, what we'll do is we'll put the answers on the website with the questions. So don't worry, rather than individual emails, that would probably be better so everybody can see that. Another question is about what non-digital support is available for those recovering at home. And they're thinking particularly, they're not exclusively of the many elderly patients who do not have access to technical access, really. I don't know if anybody has an answer to that. Obviously, you would hope that the local speech therapy service would also provide support, but I don't know if anybody has a different response. No, I don't know. Sarah, when you did the webinar for GPs, did that include how they might be able to support people who might not know about or be able to access some of the digital platforms that have been developed?
No, it wasn't. That wasn't really recovered. I'm sorry.
Okay, no worries. And somebody's asked if the GP training was also covered the UK. I'm assuming it did if it was RCGP, because they are UK wide.
Anushua might know better than me, actually. Does Royal College of GPs cover Northern Ireland and as well? Do you know?
I think it does, yes. I think it does.
Sorry to put you on the spot.
So hopefully, I'm pretty sure it does. If the person who's asked the question wants to have a look, then it would have been open to all their members. Obviously, we don't know how many would have shown up from the different devolved nations. So there is a concern about, obviously, access for people if we're not mentioned in the NICE guidance. We're not mentioned as part of the core team, but they are very aware that speech therapy might be required. I think there's a differentiation there. Obviously, we'll continue to gather the evidence to make the case that we should be part of the core team as we go through our learning and our sharing of the information that we have. So there's a question about the use of cervical osculation, excuse me if I've pronounced this incorrectly, if that has been stopped for dysphagia assessments. They've said the use of it, has been stopped for dysphagia assessments in their trust. Is there indication when this could be reintroduced?
We don't use cervical auscultation in our trust here in Birmingham because the evidence base is not very robust. And certainly I think when you're listening to upper airway secretions, for the benefit of listening to upper airway secretions when people have florid upper airway secretions as a result of COVID, both the pneumonitis, but also from a mucosal damage perspective, because we're seeing a pretty prolific laryngitis, pharyngitis picture for many people, and also glossitis later on. I personally don't know that there's a role for it and wouldn't be using it, so I can't comment on when it could be brought back in, but I think the challenge of false positives or false negatives because of the secretion burden would be significant on top of the evidence base that's available.
Okay, thank you very much.
Can I just add something? Sorry. Can I add? So I agree with you totally, Camilla, but we do use it sometimes for, with a lot of discretion. But I think the concern was around infection, and as long as you're cleaning your stethoscope, if you are normally using that tool, I don't think there's a reason not to use it any longer. It's just about being sensible about disinfection and decontamination of equipment and not sharing equipment. But yeah, I completely agree with you about lack of reliability and robust evidence. But it can be, I think, sometimes useful to see if there's upper airway airflow, for instance, potentially in a trachea when you put the cuff down and just sort of listening a little bit here and there. But yeah, we have resumed using it.
Thank you so much. So I'm aware that we've just run over by a few minutes, but I thought it would be helpful just to answer some of those questions live. I don't know if the panelists have seen any question that they particularly want to answer while we're on the webinar, or if we should take the rest through the website and get them up later.
I just wanted to make the comment actually that the question about headsets, the guidance that we wrote post-COVID, a group of us, including Sue Jones and others in Manchester, included details in an appendix about the right sort of technology. So that is available on the college website for that person who was asking.
Okay, thanks so much. Anything that anyone wants to pick up from the questions before we say farewell? Okay, can I say about clear masks that at the moment there aren't any that have been approved for use. They haven't actually gone through all the testing that's required. There is one that is going through that process now, but the clear masks that are available generally are not. They don't filter out the virus as we would expect, like the surgical masks. So they're not currently approved. So just be aware that if you're using them, they won't really be a replacement for surgical masks. Yeah, but we are waiting, as I said, for something to come onto the market. I think there's a product that's going to be tested fairly soon. So any other really big concerns that people wanted to respond to?
Just for people at home that might not, for the elderly people or people at home that don't have access to online support, all of the information on the Your COVID Recovery site that Sarah and I were part of developing is downloadable via PDF. So neighbours, friends and family can download specific sections if there are people who require that support but don't have access. And GPs can also do that for patients too. So that can support some people who have access issues.
Thank you. And I saw a question, Sarah and Camilla, about the pickups tool and whether that's UK wide. I'm assuming because it's through the Intensive Care Society, it would be, but I daren't make that assumption. Could you just confirm either way?
Yeah, any region that's covered by Intensive Care Society, unless they have their own regional something in Ireland. I think it was related to Ireland, wasn't it?
Yes, it was, yeah.
As far as I'm aware, yes, it is.
Okay. So I just want to say a really big thank you to our panellists for joining us and obviously for providing us with an incredible update on what you've learned so far, and obviously to Anushua, who's been amazing, I think, to help us really to have a sense of how it feels and your recovery, Anushua, and where you've got to now. I think we all want to wish you the best as you go forward with your recovery. But a big thank you to Camilla, Dawson, to Sarah, Wallace, Gemma, Clunie and Hannah Crawford. Thank you so much. You've been amazing. You've worked at pace as always to get this together. So we really want to say a big thank you to you, and we look forward to seeing you all again soon. Thanks for everyone for joining us, and don't forget to fill in your evaluation. That was my final point. Thanks so much. Take care, everyone, and bye-bye. Thank you.